anemia, we all know, is a chronic problem. Chronic as of that, we've been trying hard to fight it out, and with a whole lot of programs in place, still, there is nothing which has happened. So with that in mind, a series of webinars have been conceived by Dr. Sharda Jain. This is second in that series, and I'll be sharing my thoughts on what is the roadmap to Anemia Mukt Delhi. So Anemia Mukt Delhi is what we have been talking about ever since we took over Narchi last year in March. Now, anemia is a silent epidemic adversely affecting the health of individuals and economic growth globally. It is world's second largest cause of disability, responsible for 1 million deaths per year. The physical and cognitive losses due to anemia cost the developing countries up to 4% loss of GDP. So it is not only the deaths, but it is a whole lot of long-term health issues and economic losses. So anemia reduces the physical development in the form of decreased work output, decreased work capacity, and that is how economic losses. It results in impaired sexual and reproductive development, leads on to irregular menstruation, low pre-pregnancy iron stores, low birth weight babies, and preterm delivery, with its resultant long-term effects. Then reduced cognitive development, diminished concentration, disturbance in perception, and poor learning ability. So all this collectively would cause much more damage what we are actually seeing. Now, a lot of national programs to prevent anemia have been put in place by Government of India. It started way back 50 years back, is a time in 1970 when the National Nutritional Anemia Prophylaxis Program was initiated. Then its name was changed. Then came the National Iron Plus Initiative, NIPI, where the beneficiaries network was increased. And then in 2018, Anemia Mukt Bharat, in collaboration with intensified NIPI and Poshan Abhiyan, was launched. However, the mainstay in all these programs have been iron and folic acid supplementation. Now, this is what was there, which was rolled out in 2018. We did have COVID in between, and understandably, it did not get the push which it actually needed. And the target in this program in 2022 was to reduce the prevalence of anemia by about 12 points in each of the categories. So if we look at pregnant women, that time in 2016, it was 50%. And the aim was to reduce it to 32% by 2022 by 6 strategies. So very clear strategies were there. And with those, it was expected that it will come down to 32% in pregnant women and 40% in lactating women. And of course, in all the other categories too. So if we look at an NFHS 5, which was carried out in 2019-21, we see that, in Delhi, per se, there was a slight reduction to 42.2 from 46.1. But overall in India, if we look at the prevalence of anemia in pregnant women, it increased. It increased to 52.2%. So that means somewhere whatever we are doing is not working. So if we do what we have always done, we'll get what we have always got. So if we want different results, then we have to think differently. So it's time to think beyond IFA supplementation. So what do? There are other micronutrient deficiencies like vitamin B12, vitamin B6. We need to think of other routes of iron administration. We need to think of behavioral changes in healthcare providers and beneficiaries, focus counseling on intake of iron and calcium tablets and dietary advice, checking compliance at each visit, involving family members, especially spouses. So right now, what has been happening is it has been a top-down approach. There is a policy which is disseminated and everyone is supposed to follow it. But I feel that we should now go for a bottom-up approach, because we need to actually go to the frontline workers and find out as to what is it, why is it that we are unable to make a dent. So it has to be basically a combination of the two. So we need to do sensitization and empowerment of the frontline healthcare providers to identify the gaps and plug it. And also sensitization and involvement of opinion leaders, general public and media. So that means we have to make a lot of noise. So if I look at the roadmap to Anemia Mukt Delhi, I feel that the basic, the pillar would be identification of gaps in implementation of the programs by the frontline healthcare providers and plugging them with quality improvement methodology. We have very good programs. The thing is, the problem is in the implementation. And where does it fail? It fails at the periphery. So we need to look up and talk to, engage with the frontline workers and find out as to what can be done about it. So a word about quality improvement. When I use the word quality improvement, it is a set of focused activities which are designed to monitor, analyze, and improve the quality of processes in order to improve the health outcomes. And here a health outcome is prevention of anemia. So we need to identify what are these focused activities going to be. So using quality improvement methodology for reducing the prevalence of anemia in pregnancy, this is a point of care quality improvement methodology. It essentially has 4 steps. So by quality improvement, we break a complex problem into small parts and then fix up each of the parts so that the changes which we bring about are consistent and constant. So we identify a problem, write an aim statement and form a team. Then we analyze the problem and measure, identify the outcome measures, because if you don't follow your outcome measures, then you would not know whether your interventions are effective or they are not effective. Then the third step is developing and testing changes by using plan, do, study, act cycles. And the last step is sustaining improvement. So when we do in-depth analysis, I'm to say we know that the programs are not working, but we need to do in-depth analysis for the reasons why we have not been able to make a dent in the prevalence of anemia. So there are certain tools which I would like to introduce you to. These are helpful in analyzing any problem. So one is a process map, one is a fishbone analysis, then 5 whys and Pareto principle. It's just an introduction so that you can understand what it is. So this is a process flow chart. Now, if I look at the process flow chart, this is one way of, our patient comes to the OPD. This is the process flow chart, example of a process flow chart of what happens in our OPD. So the guard sends the woman inside the OPD, the clerk notes down the name and sends the woman to the nurse for a BP and weight. Then the nurse checks her BP and weight and sends her to the obstetrician for examination. And there's a technician sitting there who does a spot hemoglobin. So I made a cloud here because we are not sure who gets hemoglobin done and who sends. So this part was not clear. Then after the doctor takes the history and examines, she looks at and, she will see if the woman is looking pale. She would prescribe a hematinics and then send her back to the technician. So not everyone, the obstetrician does not have the report there on her to know whether she's actually anemic or not. Then the woman returns to the obstetrician to show the report. This is again in a cloud because some of the patients would go home. They would not come back. Some of them would not get a hemoglobin. They are in a hurry, so they go home. And if the patient comes back to the obstetrician, she would then alter the dose of the hematinics. And then the patient goes to the pharmacy to collect her, tablets because they are available free of cost. Because the pharmacy was at some distance away, so some of them would take the medicine, some of them would not take because there were no directions to tell them that this is how they have to go. And then the woman goes home. So we know there are 3 places where things need to be modified. So this is how the process flow works. So at every place one can make a process flow chart like this. Now this is a fishbone analysis or Ishikawa chart we call it. This is a Japanese professor of engineering and also a quality guru. So he's the one who proposed it. He said most of the causes are related to either policy or people or place or procedure. So in our case, this is again the example from our hospital that women, as far as policy is concerned, women were not offered hemoglobin test at 28 and 36 weeks. Albendazole was not prescribed. CBC was not ordered for all pregnant women in the first visit. CBC with peripheral smear was not ordered for women with mild anemia. Everyone used to neglect it and no information pamphlets were available. As far as procedure was concerned, many women went home without getting hemoglobin done. Many went without showing the report to the doctor. Many went without collecting the medicine. So this was a procedural problem. As far as the people were concerned, healthcare provider did not advise hemoglobin test as per GOI guidelines. Only once it was done, then maybe at 36 weeks. Then mild anemia was not flagged at all. Everyone was comfortable with a hemoglobin of 10. Anything less than 10 was worrisome. 10 plus, everyone was comfortable. Lab technician was not available at all times. Women did not get the hemoglobin done or show the report to the healthcare provider. They did not collect their medicine and take as per prescription. Pharmacists did not dispense the medicines as per prescription. So a whole lot of problems. Then as far as the place, there were no directions for reaching the lab tech or pharmacy. Pharmacy was away from the OPD and beneficiary flow was not unidirectional. So imagine so many things came up when we looked up that why is it that our women who were booked in our hospital had more than 4 visits, but when they came for childbirth, 50% of them were anemic. Then we have something which is known as 5Y. Now, when we talk about fishbone analysis, it gives you a wide spectrum of causes. 5Y helps you go into the depth. So say the question is, antenatal women were not taking iron tablets as per prescription. So we ask, why are they not taking? So the answer is because they were not getting the right number of tablets. So why are they not getting the right number of tablets? Because nursing officer is not dispensing the IFA tablets as per prescription. So why is the nursing officer not dispensing it per the prescription? Because they have only 2 types of ready-made packets. One had 30 tablets, one had 60 tablets, right? So they would just give one of the packets as per hemoglobin level documented on ANC. So we ask them to make multiple packets. Some patients are going to come back after 1 week. Some are going to come after 2 weeks. So once they started making those multiple packets and give it as per prescription, the patient would now take it as per prescription. The last tool is Pareto principle. Now, this is a very interesting principle. This was brought forward by an economist who's Wilfredo Pareto. He's an Italian economist. He said that, most of the causes, 80% of the causes can be corrected by 20% efforts. So he said that we should, if there is a problem which has multiple, reasons, then you should put them in the descending order. Say, for example, say many pregnant women are not getting their hemoglobin done. So we looked into that. So why are they not getting their hemoglobin done? So majority of the times, the technician was short of microcubics, so he could not do it. In another 30%, a technician was not on the seat because, the patient would go to him after the doctor had seen. So he would go for his lunch, or maybe he was not there at certain times. Then 10% doctor was not prescribing. And in 7%, doctor prescribed, but did not tell the patient to go to the lab technician. Okay. And in 3%, patient did not reach the technician because she got lost. So here, if we would focus on the lab technician, we will get 80%, rise in the hemoglobin assessment. So this is what is Pareto principle. It is a secret to success by achieving more with less. So now how to select which problem to fix first? We have listed so many problems. So we must always try and pick up problems which need low effort but have high value. So these are the ones which are due now. So we call it as that we should pick up the low hanging fruits first, because it will start giving us results and will keep the team motivated. So any problem which has got high value or impact but low effort, needs low effort and is easy to fix, is the one which should be picked up. All those which are low value and need high effort should be, we should not focus on them. We should focus on the ones which are due now. So I'll share my, it is not mine, it is our QI project on reducing prevalence of anemia in LHMC. We started this project way back in, June 2021. So we are more than a year, 1.5 years back we started. So first of all, we collected our baseline data. It is important that you must have a baseline data, because then you would know how much change you are going to make, and are you improving, are you not improving. So we collected it from a Lakshya register. So in our booked pregnant women, the anemia was 45.2%, and in unbooked, it was 82.3%. So because unbooked was not in our control, so we focused on the booked one. So the first step was to make our aim statement. So we aim to reduce the prevalence of anemia in booked pregnant women admitted in labor room for childbirth from 45.2% to 30% in 4 months starting from 1st June 2021. So that is what was decided. So then, your aim should have all these components. What are you going to do? You're going to reduce the prevalence of anemia. In whom are you going to do? It has to be booked pregnant women admitted in labor room for childbirth. By how much? From 45.2 to 30%. in how much time, 4 months, starting when, 1st June. So this is a smart aim. It has all the components. Then this was a flow chart I've already told you. So we made a flow chart as to what is happening as far as the hemoglobin estimation and treatment is concerned. Then this is our fishbone analysis. So we made a team. The team had consultants, had a senior nursing officer of the OPD, nursing officer, residents, registration clerk, lab technician, guard, meaning that all those who are involved should make a team. And when they work together and when they succeed, I'm to say it's everyone gives their input. So we know what is happening where. And then each one is motivated. So you must have a team which represents all the people who are involved in the management of that particular issue. And we identified our outcome indicator. So outcome indicator has to be very clear. The whole team should know what are we looking at. So it is number of booked anemic pregnant women who have a hemoglobin of less than 11 gram per cent divided by total number of booked pregnant women birthing in the unit. So this, we have to know where are we going to collect this data from. It was labor room Lakshya register. Frequency of collection was weekly and the recorder was a resident. So there are many interventions. The interventions were selected based on the problems which we had listed in the fishbone. So we started, the interventions which we did was mandatory hemoglobin testing in all women at registration as per GOI guidelines. So we did it 3 times. Registration visit 28 weeks, 36 weeks. Flagging of anemic women by lab technician. So lab technician was given small flags. So anyone which was less than 11 gram per cent, he would put a yellow flag so that everyone knows that this is an anemic woman who's coming to her. Then flagging of all women at 28 weeks by registration clerk, because we saw that we were not doing any hemoglobins at 28 weeks. So we thought that let the registration clerk mark that these are the patients who are at 28 weeks. So any patient coming in 8th month was sent for a hemoglobin and then sent to the doctor. Ensuring continuous availability of point of care hemoglobin estimation. So 2 digital, hemoglobinometers were made so that if one goes out of order, there is another one. Then the lab technician used to go for lunch. Nothing was accountable. So he had to arrange we decided to have a replacement there so that no one goes without hemoglobin assessment. Then sensitization of all doctors on additional investigations like CBC with peripheral smear for all the patients who are anemic. Even if they are less than 11 gram per cent, it is much better because we would know in case there is any other deficiency other than iron. Serum ferritin, B12, folic acid, and HPLC wherever indicated. So CBC with peripheral smear was for all as the first investigation, rest all based on the peripheral smear. Then sensitization of all doctors on additional counseling of iron and calcium intake because people were taking them together anytime they would take it. So we told them there has to be a gap of, 1 to 2 hours between iron and calcium and dietary counseling and deworming for all women. Then we set up an anemia room to focus on women with moderate anemia between 28 and 34 weeks, because that is a time we thought that we can, if they were already booked with us and their hemoglobin is not improved, then we might as well give them parenteral iron. So they were sent to the anemia room. Then ensuring continuous availability of iron tablets and deworming tablets in the OPD. So the sisters were asked and taught how to keep a buffer quota, and never should the iron and folic acid tablets go out of stock. Ensure continuous availability of hemoglobin testing during the OPD hours. Proper prescription and dispensation of hemetinics. Sometimes iron tablets would come which had different elemental iron. So we asked people to prescribe elemental iron and then asked the sister also to look it up and give it in the right dosage. And administration of parenteral iron after doing serum ferritin in those with moderate anemia between 28 and 34 weeks. That was our focus group. Additional provision of vitamin B12 tablets in OPD. Then administration of parenteral vitamin B12 and folic acid in OPD. And repeat hemoglobin 4 weeks after prescribing hemetinics. We were not following that. Then because there are shortage of beds and the number of patients are more, so line listing and staggered admissions for parenteral iron. So we would put their phone numbers and call them as and when the ferritin reports would come and call them for injectable. So all these interventions were introduced. And this is what happened after the, flow chart after the intervention. So women reached the OPD for antenatal visit, guard would send the patient to the OPD, registration clerk would, do the registration, send to the nurse. the nurse would now identify those who were at 28 and 36 weeks and first visit. She would make sure that they were directly sent for hemoglobin. Technician would do the hemoglobin and put a colored identifier that this is the patient, and also have a dietary advice chart he would give to the anemic woman, who would then take it to the doctor. So then the doctor would screen and see whether the hemoglobin is done. Sometimes the patients went without hemoglobin, then the doctor would send them back to the technician. So, and then we shifted the dispensing of pharmacy in the OPD only. So the woman, if the woman, after the doctor had seen, so she would be given proper advice, and her CBC and other things would be done. And then if she was 28 to 34 weeks with a hemoglobin of less than 10 gram%, she would be sent to anemia room, so that someone would take charge of her and prepare her for parenteral. And then she would collect the medicines from the pharmacy and would leave for home. So this is what was the flow after we finished with that. And so after the interventions are put in. So these were the charts initially, they were in English, then we put some Hindi titles to it so that she could understand. So this is what happened. This is our time series chart. So initially you can see the median was here at around 50, then it came down to about above 30, but it was here, then we thought of giving parenteral iron. This was almost after 6 to 8 months, we could not reach our target. So then we came with that intervention of giving parenteral to all those who were between 28 and 34 weeks, and we reached our target. So we stayed at about 22% here. And again, it went up. So I'm to say, tracking this helps us know whether things are in place or they are not in place. And another interesting thing was, although we had about 25% still who were anemic, but if you see here, the blue line shows mild anemia and the red line shows moderate anemia. So there were more patients with mild anemia and there were lesser patients with moderate anemia. So it is because we took the cutoff as 11, so that is why we still had 20-25% patients who were anemic. So a word about vitamin B12 deficiency. So in this project, when we saw a huge number of patients who had vitamin B12 deficiency. So vitamin B12 deficiency in Indian women during pregnancy range between 40 to 70%. It is more in northern and western part of India. With the advancement of pregnancy and increased fetal demands, the concentration of B12 in the blood falls, and the proportion of vitamin B12 deficient women increases. That is why there is a crash fall. If your patient is taking hematinics religiously and her hemoglobin falls or does not improve in the last trimester, think of B12 deficiency. Babies who are born with B12 to B12 deficient mothers are also B12 deficient. And vitamin B12 deficiency in anyone has a lot of harmful effects. So although it is widely prevalent, vitamin B12 supplementation is not a part of public health policy in India. And I think high time that we start looking at that. So this is a study which was conducted in our own hospital. So this is the data from 100 patients who were registered at the first visit, and we took their hemoglobin, their B12 levels and their folic acid levels. Interestingly, 60% of them were B12 deficient. And at the same time, 97% of them were folate replete. So imagine, we keep giving them iron, folic acid, but we don't think of B12 at all. So now looking at what are the features of vitamin B12 deficiency. It is very subtle. It is like any other patient of anemia. There would be fatigue, pallor. Jaundice is additional. Glossitis again tells you that there are multiple deficiencies. But I think we need to focus, and even peripheral neuropathy and neuropsychiatric disturbances, we don't come across these because these are in more chronic patients. In our pregnant women, they become B12 deficient because the increased requirement due to pregnancy. So initially they may be borderline, and in pregnancy they dip. So hyperpigmentation, knuckle hyperpigmentation is something which is a very important feature of it. And then if you look at the investigations a little more carefully, you can pick up. So if MCV is more than 100, sometimes in a patient who is say 8 gram%, her MCV is 92 or even above 90, it would mean that she's got some more deficiency other than iron. So, a lot of clues come out of it. Then the peripheral smear, and sometimes even normocytic normochromic picture would mean that they could be B12 deficient. Hypersegmented neutrophils, coexistence of thrombocytopenia or leukopenia, evidence of hemolytic jaundice. If you do vitamin B12 levels, then less than 200 is definitely a deficiency, but 200 to 300 are also borderline. So these are the patients who need vitamin B12 supplementation during their pregnancy. So this is an interesting ICMR STS project which we did. So we were thinking that it may not be cost effective to do vitamin B12 levels in all our patients, in the first visit to pick up all those 60%. So we took up 250 random pregnant patients. They were assessed for the presence or absence of knuckle pigmentation, hyperpigmentation, their hemoglobin, folic acid and B12 levels. And very interesting findings came. Out of these 250 patients, 52% were anemic. It is in line with what the government says. But 73.1% were vitamin B12 deficient of these anemic patients. So that means we don't treat these patients. Knuckle hyperpigmentation and anemia. If we combine these two, 86.3% were vitamin B12 deficient. Then clinical pallor and knuckle hyperpigmentation. If patient was clinically pale and she had knuckle hyperpigmentation, 92% were B12 deficient. And women who had dimorphic anemia or any macrocyte in case on their peripheral smear, 94.7% were B12 deficient. So imagine we don't give B12, no? So such a big group of patients is untreated. So if it is untreated, how are we expecting that the women would be free of anemia when they deliver? So we concluded that knuckle hyperpigmentation and macrocytosis in women with anemia can diagnose vitamin B12 deficiency in more than 97% of pregnant women in an affordable manner. So this is a meta-analysis, systematic review, which you must see. See how many conditions are related to low levels of vitamin B12, right? It is not only pregnancy related, but even long-term, a poor cognitive development, higher adiposity, insulin resistance, a whole lot of problems are related to vitamin B12 deficiency. High time that we start looking at vitamin B12 deficiency in our population. So just an example of how do you diagnose it. So this was a patient who had come to us. She came to us in June, right? That was the first registration visit. She was 10.1 gram %. But MCV was 92.4. So, and MCH was low, that was 27.5. So, she came after a month, she was given iron folic acid, her hemoglobin fell down to 9.6. So that is a time when the doctor also got a peripheral smear done. It showed a dimorphic picture. So probably, again, iron folic acid was continued. And after 2 months when she came, her hemoglobin fell down to 9.2 gram % now. Okay, so that's the time when her serum levels were done. Ferritin was 42.8, B12 was 304, folate was 13, HPLC was normal. So here they thought that B12 is normal, folate is normal. So ferritin was 42.8, so she was given parenteral iron because she was 28 weeks here. Again, no B12 was given to her. And then she came to us after another month and she was 9.4 gram %, a slight rise. And because now erythropoiesis had increased because of, more of iron supplementation, and within a month, at 36 weeks, she was 8.9 grams. Now imagine she's been with us, but somehow we missed all the indicators of giving her vitamin B12, and we ended up having a moderate anemia despite her coming to us regularly. So this is a case where we failed. So failure is not the opposite of success. It is part of success. So if we can interpret it and we can learn from it, I think it will help us improving further. So treatment of B12 deficiency, I need not go into the details, but there is a lot of variation. I'm saying you can give it oral, you can give it parenteral. Majority of patients are not pernicious anemia. So you can give them oral, provided there will be compliance. Otherwise, a single shot of vitamin B12 is sufficient, 1000 micrograms. We did a study wherein we gave only one shot. Now, vitamin B12 is stored in the liver for more than 400 days. And in pregnancy, if you give even a single shot or maybe 2 shots, that should be good enough for the patient. And here the patients were given a single shot, and after 4 weeks, the hemoglobin showed a significant increase, B12 level showed a significant increase, and MCV showed a significant decrease. Everything was statistically significant. So I'm to say, if we think our patient is not going to come back, especially in public healthcare settings, we can give them one shot right in the OPD, and that is what we did in our QI project. So this is a success story. So this patient came to us with a hemoglobin of 7.3 gram %. So that was the first visit, although she was at 28 weeks. So we asked her, she said she will take it orally. And when we did a ferritin, it was 25.3. That was done as a routine. But then because she said she will take orally, then we asked her to continue, and she became 9.8 after a period of about 1.5 months. And then after another 1 month, she became 12.1. So this is a success story, provided you look at it and you counsel the patient and ask her to take the right. So the practice, we need to practice the philosophy of continuous improvement, get a little bit better every single day. So these were a lot of, that bottom-up approach. We did a lot of, contact programs with ASHA workers. And interestingly, when you would ask them, what is the level at which you would think the patient is anemic, everyone said 7 gram%, because they do a line listing at 7 gram%. So we interacted with them. We asked them to do their own hemoglobins and make it 12 and then get it done for their patients. So, all the hospitals came. We had people leading, Dr. Mani from Guru Gobind Singh, then we had Dr. Poonam from Sanjay Gandhi, Dr. Anita from Hedgever, then, DDU, Dr. Sushma from, not Dr. Sushma, Dr. Shashi from DDU. And this is our own Kalyan Puri Center with Lydia. So we have trained about more than 400, 500 ASHAs. Then we thought that this is a very slow progress. So that was done over from April till, August. Then we thought we had Narshikon, which was there. Then we did a training of trainers. So Dr. Jyoti Sachdeva and Dr. Vandana Bagga, Dr. Monica Rana all came forward. So we had people from government and private hospitals, including Ayush and homeopathic doctors. They were trained and they were provided with an anemia toolkit. So we had Dr. Swati, Dr. Shilpi, all these people, they got together, they prepared the slides. Dr. Kanika was there, so they prepared the slides. And we have a set now, we have given it to all the people who were there, and we've asked them to cascade it and go and train their frontline workers, ask them, train them in QI, ask them to fix their own problems. Then 14 December, Dr. Ashla Batra had taken the lead, and we had another, Narchi event, Anaemia Mukt Delhi, turning vision into reality. And, we talked about it. We had Dr. Sharda Jain and Dr. Kamal Bakshi there, and we talked about our vision and shared our views with many people. And then came Dr. Sharda Jain's initiative, where she planned a series of webinars on 9th of each month, starting on 9th December. And she said that we'll have it every month, and we'll continue having, and keep on adding more and more ambassadors for the cause for prevention of anemia. So nothing is impossible. The word itself says I am possible, but to have a focused, target, to reach our target, we have to be patient. We have to have patience. We have to be persistent. We should have perseverance. We have to be passionate, and we have to be very purposeful. So this is my favorite quote. I'll end it with that a small group of determined and like-minded people can change the course of history. And for faster results, we need linkages, we need teamwork, we need to onboard more and more champions. And obstetricians and gynecologists need to take the lead for Anaemia Mukt Delhi, because they are the ones who get in contact with the whole family and with the newborn even before the baby is born. So I think we really need to, get together and move towards fulfilling our dream of Anaemia Mukt Delhi. Thank you so much for patient here.
Thank you so much, ma'am. Excellent presentation of the initiative of Anaemia Mukt Bharat, Anaemia Mukt Delhi. I request our experts who are present in the meeting to please give their comments. We have Dr. Asmita Rathore, ma'am, with us.
Yeah, good afternoon. Am I audible?
Yes, ma'am, you're audible.
Yes, ma'am.
Yeah. Thank you, Dr. Manju. It was really an excellent presentation with all very, very practical tips. And I fully agree with Dr. Manju that I would like to start with the residents in our hospitals who see huge number of patients, and somehow in their mind that figure or a definition of anemia is set at a different level. 8 or 9 grams, they don't think something very serious. And I think that is the point where I would like to always emphasize and sort to resensitize them that keep the figure of 12 in your mind so that you get alert at an earlier level and act aggressively. I have started an anemia room and now slowly making progress on counseling our patients on diet, and we have a dietitian sitting in the room. it was very interesting to know the study about the role of a knuckle pigmentation in detecting vitamin B12 deficiency. And I really agree that it's a very simple intervention and which can be used by all of us. Probably I at least was not so aware that such a simple sign is so has such a good sensitivity to detect B12 deficiency. And B12 deficiency has a very peculiar presentation that it's not only anemia, but it's a sort of an picture where patient have a low platelet count and anemia which doesn't respond to your oral iron. So if we detect and intervene early, it can be a very useful thing. And I think, yes, it's a very, very important agenda and all of us have to work together. And as an AOGD, I think I will also like to have some sensitization of all our AOGD team also. And we will also work in that particular. Thank you so much, Manju. I think it's a long project, but under your leadership, you all will do well. Thank you so much.
I think,
Thank you,
Dr.
ma'am.
Manju, as I told you last time, I'm delighted. And I feel it is doable. And having worked both in the medical college and now in a private sector, I find, the private sector things will be probably more easy. And the only thing is we need to monitor ourselves, and I can definitely say we can take nursing home wise, institution wise, and everybody has to be this thing. And I'm really glad and delighted that at this age, I learned the other day that vitamin B12 deficiency can be so common, especially when your patient is not improving in spite of your best effort, that it is B12 which is creating a problem. And I think I'm very hopeful. I'm absolutely delighted about it. And I will see to it that at least 50% of the people who are private practitioners monitor their patients' hemoglobin right in the clinic before they leave the clinic. And they should have a set counseling as far as the nutrition is concerned, deworming is concerned. We used to, now hardly anybody is doing deworming, but I think, as you said, that after first trimester, deworming should be routine for even pregnant patient, especially if she is moderate anemia and less. So I think I'm excited. Dr. Sadhna?
Thank you. Dr. Sadhna, ma'am. Yes.
Thank you, Dr. Manju Puri. As we see to you as we can learn a lot from you. It is not only Delhi, it is a whole North India and whole nation. So first of all, the very, very important thing that was the system, a very root analysis that where we get lost and we don't get, because in our practice sometimes the patient gets hemoglobin and she comes after 1 month when her hemoglobin actually has to be repeated. So here is a big gap, and be it a small person, nursing home, or a be it institution, this is the point where we have to look at it. It is just a streamlining of system and very, very doable. So very, very important thing. And second thing about B12 deficiency, so actually what your research have already, what I have projected, actually in the developing world, it is now the WHO's statement also echoes your research, that it is not only iron deficiency anemia, actually it is multiple micronutrient deficiency, which is the cause of our failure to treat iron deficiency anemia. So I put the question to all the people, like getting serum ferritin B12 level and the folic acid estimation seems to be very far off. So like combining iron with the B12 and folic acid in a good dose, and of course what a hyperpigmentation, or what is a clinician observation, simple observation, that we supplement everybody with the multiple micronutrient, it will correct anemia. Not only correct anemia, it will correct the adverse obstetrical outcome, like by reducing homocystinuria. So likewise, if we do the research, I think we will really get the deficiency of iodine, we will really get the deficiency of B6 also. So that also lead to overall obstetrical outcome. So this is a thing like we have been like propagating now, that it is not the time of only iron and folic acid, but it is a multiple micronutrient deficiency. And the third is on our part, that the reading ABC of CBC. It has been our great, like all learning, like in all our educational program, learn the ABC to CBC, so we can identify megaloblastic anemia, we can identify the dimorphic anemia, and we can do a lot in the, not only in the first, but also the follow-up of the patient. So serum ferritin, yes, but B12, folic acid, I think we are not able to take, and the single injection. So it is a hyperpigmentation, it is neuropathy. There is nothing, very, very low cost treatment that we can do the injectable Vitcofol, and what we do to each other. So thank you very much for the wonderful insight, and as a presidential candidate and as a president NIGF, we will surely see that what your input, which your deep research and deep experience, we will carry forward your views and the action to the benefit of on the larger scale. And of course, Delhi is the capital, so Delhi always shows the way. So thank you very much for excellent presentation, and we have it is a really stimulating session for the many new ideas. Thank you very much.
Thank you, ma'am.
Dr. Sangeeta?
Thank you.
Thanks, Dr. Puri. It was really a very good talk, and I think whatever process deficiencies you have highlighted are the same in all the government organizations. So we have again to focus on those 5 whys and to focus on the problem where solving that problem can give us the maximum benefit. So that availability of the technician, availability of the equipment, and report receiving by the patient and reading by the doctors. These are very, very important points, and all government doctors have to focus on the points highlighted by you. Secondly, while we are treating the other disorders, like other than pregnancy, like AUB, like most of the anemia cases which report to our OPD are the cases who have taken over the counter abortion pill and have not been followed properly and have kept on bleeding, and they report to us. While they started, they were 12, 13, but now with 7, 8. So other problems which are there, we should highlight anemia problem along with treating those problems. May it be adolescent problem, may it be AUB, may it be a cooperative follow-up, or may it be prescribing medical abortion pills. So simultaneously, we have to take care of hemoglobin level up to all those patients. And I think if we all join together, if we all focus together, we'll be very soon achieving our targets. Thanks.
Thank you, ma'am. Dr. Sonal, ma'am.
Excellent presentation, ma'am, and very nice data you presented. It's a very important point to note that deworming of all the patients is important, and secondly, don't ignore an HB of 10 grams per cent. I think this is a very good take-home message. Ma'am, we started with the routine B12 estimation and routine D3 estimation in our patients for past 2 years now. We have incorporated into our antenatal cards also. And the prevalence of B12 deficiency is quite high. And it's not easy for patients to tolerate B12 supplementation along with iron during pregnancy. So what I, as a personal practice, I do is that I always start the patients on pentoperazole with iron when I'm starting iron, so that they don't give up taking iron. And once they are settled for 15 days, then I withdraw pentoperazole. And second thing is, for B12 supplementation, there is an inhaler available, which is in the name of Rhinocobal. It's 20 mcg, which is very helpful for the patient. So any patient who has a B12 level of less than 200, I give them this Rhinocobal inhaler, and it really helps in building up the B12 levels and brings the hemoglobin back to normal. And similarly, our neonatologists, they suggested us to introduce D3 estimation also. So we started with that also. In private practice, I think it is available. And a very important point Dr. Sangeeta has touched, I think we should somehow discourage the over-the-counter availability of MTP pills. We must find out some way so that these drugs are not available all over the counter, because there is nobody to follow these patients up. Thank you very much for the opportunity. It was a great learning experience.
Thank you.
Thank you, ma'am. Dr. Medalini Mani, ma'am.
Yeah, good evening, everyone. And at the outset, I must say thanks, Dr. everyone, for taking this initiative. And I'm very fortunate to be associated with Dr. Manju ma'am from the beginning of this project. Simultaneously with ma'am, we started in June 21 for our patients' antenatal. And the results were amazing. And we took up a bottom-up approach because we knew that somehow we dispense a lot of medication to all our patients, but still they were anemic when they were coming to us. And our baseline data in the OPD was to the tune of 60% and IPD delivering patient 46%. So we started training, including our all sisters and guards also, when to take iron, how to take iron, so that most of the time patients talk to them when they are waiting, and these people become counselors. So we took this opportunity and taught them how to do a proper counseling regarding the diet and taking of medication, which was so important. And yes, we were adding multivitamin earlier. Now we have switched over to B complex and also asking for B complex injections with us. And over this 1 year's journey, rather 1.5 years, the results have been very heartening. And I'm proud to say that my booked indoor patient, now the anemia is only 7%, all mild, moderate, and severe combined. OPD, yes, we are still lagging behind because patients are coming from the field and we have to catch them. But from 60% plus, it has come down to about 32% at the moment. So we are very hopeful. And one initiative for Anemia Mukt Delhi, what we have started, I started in my hospital, training, catching hold of group C and D employees and cascading to them. And also, madam, we have requested our MS to test each and every family member of our employees from the beginning, start from home. घर से शुरू करेंगे तो हम बाहर जाके फील्ड में कैच करेंगे. तो हम अपने सारे हॉस्पिटल एम्प्लॉयज का कर रहे हैं area wise, so that we encourage them to bring their families over and get everyone HB tested. So we have about 1,500 odd employees. So we are starting from there ahead. Plus the patients, of course, the antenatals and adolescent girls which come to us. And also any women coming to gynae OPD, we are testing, getting their complete profile done. So I think combined, we should be able to make at least Delhi Anemia Mukt very soon, and a step forward if everyone takes. Yeah.
Great. Wonderful.
Great, ma'am. We can have comments from Dr. Jyoti Bhaskar, ma'am.
I think everyone has put in so much that today I feel I need to do something. I need to start from today. Only one thing I felt, Madam Dr. Manju always talks about quality improvement. She being in a sector in the government, you talk about quality improvement in the OPD and at a much larger level. But I feel everything starts from us. So this whole steps of quality improvement, while you were talking, I was saying that if I change my practice, then at every level, whether am I interpreting the CBC properly, am I writing the PS for the patient, am I deworming the patient? If she comes to me at 28 to 34 weeks, hemoglobin less than 10, am I evaluating her, giving her parenteral iron? I think if each of these steps of quality improvement, I start doing it in myself, I'm definitely going to make a difference as far as my patients start. So instead of just advocating everyone do it, I think we need to start right now, at this particular moment, changing our own practice before we can do it. And second point that I really liked, and I have also started, is that between 28 to 34 weeks, despite taking iron treatment that she is generally on in private practice, if her hemoglobin is less, that's an opportunity, if it still turns out to be an iron deficiency, to give her a parenteral iron. And that makes a huge difference, because when she comes at 36 weeks, she's already more than 12. So instead of just pulling on thoda din aur le lo, double dose le lo, we do that. I think that's the right time to even think about giving her a parenteral iron. So thank you very much. In B12, yes, there are many combinations. I feel nowadays we have some of the calcium combinations which are also giving 1,500 micrograms of B12. So if you really find them to be deficient, probably they all take calcium. Instead of adding an extra vitamin, probably we give them the ones which have the B12. So that can also tend to be working on. So thank you very much.
Yes, ma'am. Thank you, ma'am. Dr. Kiran Chhabra, ma'am.
Good afternoon, everyone. Thank you, Dr. Manju Puri, for your excellent deliberation. You are always a torchbearer, and as you have suggested and guided us how to fill the gaps in diagnosing anemia, in interpreting the PCV, that complete hemogram, we will definitely be doing much better in our practices. Though in my kind of practice, I'm already giving B12 in the first trimester to the patients along with folic acid. I get complete hemogram thrice in 9 months. And as Dr. Jyoti has suggested that give parenteral iron between 28 to 34 weeks, that also I'm trying to do and giving my patients parenteral iron so that by the time they deliver, they have a good amount of hemoglobin in their bodies. So thank you very much for such an excellent deliberation and guiding us.
Thank you.
We have Dr. Mitra Saxena from Rewari. You want to make any comment, Dr. Sahab, in practice? How you can make
very good afternoon, good evening to everybody. I think that everything has been said by whatever feelings were in my heart and brain have already been expressed. And really, as Dr. Jyoti and others have said, charity begins at home. So the good thing about attending today's session is that it is Dr. Manju Puri's motivation to make anemia free Delhi. But I think we have understood a lot of simple facts about why our patients are not showing improvement. So like a good teacher makes things very simplified. So I would say that just looking at the CBC and understanding the relevance of all those indices, the MCV, I mean, little clues, and just a reminder by Dr. Manju Puri, I'm sure that at least all of us who are here will be doing correct justice to our patients. And moreover, if somebody sets their heart to do something, achieve something, we are all sure to reach that. So all the best to you, dear Manju, respected Dr. Sharda Jain. Ma'am, when you take up a project, you make sure that everybody, दुनिया का भला होना हो, हमारा खुद का भला जरूर होता है. So learning something correct, accurate has been a very fantastic blessing for me. Thank you so much, ma'am. Thank you, all of you.
I think anemia is dear to everybody's heart, and a shock coming to all of us in 2018 that instead of decreasing, we are definitely increasing. And there's something basically wrong with our quality management as for the patient care is concerned. And I think, the private practitioners, when they deliver patients, their target should be 12 %. And for the private people who are working in the government sector, they should see to it that the anemia incidence of less than 11 gram%. If Dr. Mani can do it 7%, I'm sure it will be possible if Dr. Manju Puri keeps, as far as the direction is concerned, as far as the government sector is concerned. Manju Puri, I have worked in the same setting up, and I find, if you could motivate hemoglobin being done now for 3 or 4 times during pregnancy time is a great achievement as far as Lady Hardinge Medical College is concerned. And we see the absolutely contrast in the governments in the private sector. Here to get a hemoglobin is not a problem. You have to be obsessed here. This lady should not go less than 11 gram% when she's going into labor. And when I say it can be 12, for the last 3 years, I have to see into it that hardly ever any single patient of ours hemoglobin is less than 12 gram%. It is all setting up your mind. And I'm sure in a private sector, we will see to it that things are definitely improved. And the only thing is with your team and the government of Delhi team joining your hands, by the end of 2 years, you will find the incidence of even mild anemia will not be there in this in Delhi. So if the Delhi shows the roadmap, I'm sure everybody will be able to do this. But I'm indebted to you as for the B12 deficiency is concerned. If you just look at the knuckles, and your job is done.
That's
finally a student tells you that madam 75% will have B12 deficiency. एक छोटी सी चीज हमको इतने दिन लगे, इतने बार सफेद करके पता चला कि B12 की डेफिशिएंसी नकल्स में छुपी हुई है.
That's a good take-home point, ma'am. And I think instead of a just routine iron folic acid supplementation, we should have a multi-micronutrient supplementation. Instead of a plain calcium tablet, we should have a calcium vitamin B12 tablets for routine antenatal supplementation.
I think this hunger as for the micronutrients are concerned, the country is highlighting it time and again, and we are for the last 2 years thinking about it. And I think over and above, Dr. Sadhana Gupta is on a mission to inform each and every gynecologist that micronutrient deficiency is very, very important. And the right time to give it to up is not only folic acid. The first trimester, you should flood in these micronutrient deficiency, and without much of cost, I think, So these two new things have come up as far as the pregnancy part is concerned. And I think each and every one of us should know the counseling part of it. And the senior gynecologist should spend about 5 to 10 minutes counseling them about the nutrition and relating it to the IQ of the child. If you relate it to the IQ of the child, I think things are going to really do wonders. Patient ही आपको कहेगी मैडम आप मेरा हीमोग्लोबिन कराओ, मेरे बच्चे का IQ कितना है?
मैम बिल्कुल ये हमारे यहाँ ऐसा ही हो गया, पेशेंट खुद से पूछे मेरा हीमोग्लोबिन ड्यू था, मैम वो करवाओ, ऐसा वाला उनको बताते हैं कि आपको याद दिलाना है, अब 4 हफ्ते में आएंगे दोबारा होगा. So the moment you link it to the IQ of the baby, they all want to get it done, and
the people who have worked with me don't know it. Our patients keep chasing us, doctor साहब आपने हीमोग्लोबिन तो कराया नहीं आज.